We are so grateful to have this next panel for all of you, and it is on women's health equity, maternal health in focus. Thank you for the work that you do to ensure that other Latinas and other women of color don't have to experience having their babies not survive or in a NICU. So one of the most prevalent ways we see this issue manifested is by looking at maternal health outcomes for women of color. Our panelists are leaders across all sectors of the healthcare system and the continuum and policy, and will share the work they are doing in the front lines to close the health disparities for Latinas. To our attendees, this is an opportunity to ask questions and also to just really, as Max did, with the other panelists, really just learn and ask the questions. If you want to submit a question, we do have the index cards still on the table. Make sure that you're getting those questions in. And so I'm going to go ahead and start similarly. So we're going to do a time check too. We're running a little bit late, but I just want to first start with you, each panelist, introducing yourself and your role in closing the health disparities for women in the state.
Thank you. Thank you so much, Celinda, and thank you all for being here this afternoon. It's an honor to join you at this wonderful event. As was mentioned, my name is Diana Robles. I am an OBGYN physician in the San Francisco Bay Area, and I specialize in caring for pregnant people with complex medical problems that may impact their health during their pregnancy or the health of their baby. My family is originally from Mexico, and I grew up on the US-Mexico border in southern Arizona, in a small town, some of you may know, Nogales, Arizona. And I was inspired to go into medicine really from our lived experience, seeing how the US healthcare system was really poorly positioned to care for our international and primarily Spanish-speaking community. So I was inspired to go into OBGYN and medical school and got more excited about focusing my career in obstetrics. And so was nearing about an additional 10 years after medical school to become a fully trained maternal fetal medicine specialist, and then the pandemic hit. And I found myself increasingly frustrated by the huge health inequities that were really apparent. They were well known in our community before the pandemic, but they were really brought to the forefront, and especially impacting the Black, Indigenous, and Latina patients in my care. So I decided to channel that frustration by joining the National Clinician Scholars Program. The NCSP is a 2-year health policy and health services research fellowship that focuses on advancing health and healthcare through scholarship and action. So through the NCSP, I've explored the impact of state and federal policies that expand public insurance access to perinatal services within immigrant communities. And I'm also studying how language barriers influence the kind of hospital-based care people get after delivery in the postpartum period. So my long-term goal is to be able to leverage my cultural heritage with my clinical expertise and to advance health equity and perinatal health through community-centered and policy-relevant scholarship and service. So this mission is what brings me here today, to share my experience with you all and to learn from these other wonderful leaders, to share in this conversation on women's health, equity, and maternal health, and to keep working towards improving the health and wellness of our entire community.
Thank you. Tiffany? Same question.
Hi, everyone. Thanks for having me here today. My name is Tiffany Matthews, and I am a Deputy Attorney General and Legislative Advocate at the California Department of Justice. And my portfolio within the office covers health and education matters. So I've done work with strengthening reproductive rights and increasing access for affordable and quality health care for Californians. And I've been involved in this work now for a few years. I've always been interested in healthcare and have wanted to put my time and energy towards ensuring that everyone in California can have access to healthcare, because healthcare is life and we all need it. And so later today, when I talk about the specific work that the Department of Justice is doing in legislation this year, then I'll touch on how we are accomplishing that or attempting to this year. Thank you.
Thank you.
Hi, everyone, and thank you for having me. I am Yohualli Anaya, Dr. Anaya. I am a family medicine primary care physician. I am a researcher. I am an educator for medical students and for residents who are doing their family medicine specialty training. And I am an immigrant Latina. I was formerly undocumented, and I am now a physician. And as we have these conversations today, these hard conversations, I want you to know that I need you. I need you. And that's why I'm here today. I was born in Mexico, and I immigrated when I was 4 years old. And I was 5 years old when I decided to become a doctor in this country, seeing the need for Latinas like myself. I am a researcher with the Center for the Study of Latino Health and Culture at UCLA. And my journey has brought me now to the Midwest, where I'm still doing all the work that I was doing formerly at UCLA, now also having the privilege to do that in the Midwest with another very special community. And my vision is to be able to contribute to health equity through the development of research that informs policy, because that is how we can move things forward. And so I'm looking forward to kind of sharing some of my work with you about that as well.
Thank you.
Good afternoon. I'm Assemblymember Mia Bonta, and I represent the beautiful people of Oakland, Alameda, and Emeryville. I hear there are about 90 of us in the room. First, I just wanted to congratulate Hope and Helen for this moment. 30 years of Latina Advocacy Days is just phenomenal, really. And to know that in a few hours, you all are going to be storming the Capitol just fills my heart with such joy. So I just wanted to put that out there. I am currently the chair of Assembly Health. It's a new thing for me, but I'm very, very excited about it. I came to the legislature with my own lived experience of having experienced on 3 different occasions moments of bias where I was told I was drug seeking one time. I was another time after 2 years after giving birth to my daughter, had a chronic illness that went undiagnosed for those 2 years and literally had to yell at the doctor and the insurance company to just give me a simple test that indicated something that was curable and workable. So, I came to the role of being health committee chair with that particular experience of understanding that Latinas and Black women for far too long are often overrepresented in issues of maternal health and maternal mortality and morbidity, and it has to stop. So definitely focused on not only the equity focus within that, but also really wanting to make sure that we are centering our experiences within our healthcare system so that that kind of bias and discrimination doesn't go on any longer. Some of the legislation that I have carried last year was really focused on reproductive health and reproductive justice. And this year, we're digging into ensuring that we have an opportunity to look at some of the foundational factors associated with bias. So I think Laura came to talk with you earlier about my AB 3199. I'm very thankful that you all will be storming the Capitol talking about that bill. And then also championing and working on AB 2319, authored by my colleague Lori Wilson, to require all health providers who interact with prenatal patients to complete implicit bias training. So focused on not only training, bias, diversifying our healthcare workforce, ensuring that we have a strong representation of Latinas and Black women, especially within all aspects of our healthcare system, doulas, midwives, healthcare advocates, promotoras, chairs of divisions within our hospital systems, so that we can be represented in all aspects of our work, and very much proud to be with this amazing panel.
Thank you. We're honored to have all of you. This question is for Dr. Robles. As a maternal fetal medicine doctor, you have firsthand experience providing care to birthing women. Could you share some thoughts, some insights into, if I could get this to work, that would be fantastic. Max, how did you do this? Okay. The specific challenges you have witnessed that contribute to the disparities, the disparate maternal health outcomes and disparities we see for communities of color.
Thank you so much for that really important question. And I really have to say that the gravity of the U.S. maternal health crisis cannot be overstated, and the disparities that we see in our communities of color are really critical. So the newest figures for 2022, in terms, there's a delay in data, and so we have the newest figures for 2022 in terms of maternal mortality rates, and there is some improvement, and with a decrease to 22.3 deaths in 100,000 births in the US from 32.9 deaths per 100,000 births in 2022. And important to remember that during the pandemic, these rates skyrocketed, and in particular, skyrocketed for communities of color. In the Latina community, there was a 44% increase in 2021 from previous years in terms of maternal mortality. And it's really important for me as a physician to recognize, and this is data from maternal mortality review committees across the country, 4 out of every 5 pregnancy-related deaths are preventable. So we have really high rates compared to other developed countries, and these are things that are preventable. We can intervene, and we are failing to do so. Some of the leading underlying causes for pregnancy-related deaths are maternal health. This is the leading cause of maternal pregnancy-related death in the Latina community, and as well in the white and Asian population. Excessive bleeding or hemorrhage, and heart disease, cardiac or coronary conditions, and that is currently still the leading cause of pregnancy-related death in the Black community. And despite efforts to reduce racial disparity and ethnic disparities, the maternal mortality rate in the Black birthing community is outrageously overrepresented in these numbers, over 2 times higher than their white counterparts. And it's important for us to talk about maternal mortality, but it's not the only patient-centered outcome that we should be caring about. Discrimination in pregnancy and in their delivery and postpartum period is also really important. In the Listening to Latina Mothers in California study that was reported in 2018, over 5% of Latina mothers reported that they were being treated unfairly in pregnancy and postpartum. And over 10% of pregnant people who report Spanish as their primary language reported being treated unfairly because of their language. This is our community. And these inequities persist because of the discriminatory and frankly racist systems that patients from minoritized and marginalized backgrounds are forced to navigate. These are systems that restrict access to safe, healthy, and resource-rich environments. Systems that people in power and the people who influence power can control, and we can influence these systems. It's also important to recognize that these systems also cause weathering, this idea of just exhaustion from the weight of having to navigate inequities and discrimination in your everyday life, and that can directly harm our health. So let me share kind of a patient scenario, how this might play out for me as a physician in the specialty care I provide. So I have training to be able to help someone who has high blood pressure outside of pregnancy, needs medications, now they become pregnant. I can help them manage their blood pressure through their pregnancy, make sure they take pregnancy-safe medications, monitor for any complications to their health or the health of their developing baby. Now, if my patient that is assigned to my clinic has transportation issues because they live in a community that has historically been affected by redlining, so they don't have access to the most common bus routes. If my patient doesn't have the ability to take time off work because they don't have alternative options for an employer that has more flexibility, doesn't have access to childcare, and they are a parent, they have other children. So hospital policies that restrict their ability to bring in a child with them to an appointment is going to make them miss that appointment. What if our patient doesn't speak English, or English is their second language, they have another preferred language? All of their appointment reminders are in English, all of the signage in the hospitals and clinic are in a different language. So they miss appointment reminders, they don't know how to find the clinic, they arrive late, there's a late policy, the patient is not seen. So any of these structural problems, these are problems that we can control as members of the community that are disproportionately affecting the patients I care for. All of those problems will result in a missed appointment, several missed appointments. Patient presents for delivery, they go into labor, and we review their chart, they've missed a lot of prenatal care. They're labeled as non-adherent to their prenatal care. And that introduces a bias from the care team, assumption that that patient doesn't care about their health and doesn't care about the unborn baby. And that bias is going to negatively impact how they're cared for throughout their hospitalization and postpartum. But all of the barriers to care were part of a system, a structure that we can influence, that we can improve. So what I've just outlined, that's just a small part of like this larger, more comprehensive and complex web of reasons that health disparities are driving our current mortality crisis. But the good news is that we have leaders in California, like Assemblymember Bonta, and many more people in this room and in the Capitol that are working to really make a difference, especially in understanding these structural determinants, these social determinants of health. So AB 3161 and AB 2319, I really think that they'll help our healthcare facilities and healthcare providers like me, Dr. Anaya and others, to do more to combat all of these structural problems that we can actually influence and ultimately dismantle the inequitable structures that harm the health of our entire community. We need to know the data, and that's what AB 3161 is going to help us do, is understand when something bad happens, when there's a poor outcome, what are the factors leading to that poor outcome that we could potentially influence, that hospitals can be responsible for. And with AB 2319, we've already started to roll out. I've taken a lot of the racism and discrimination trainings that are really important to think about in birth and postpartum. But we need to make sure that we're actually using those trainings to get the right outcomes. And these are ways that we can make sure that those are happening in the hospitals that we care for our patients.
Wow, thank you so much. The next question is for Dr. Anaya. You have been a leader in highlighting the dire Latina physician shortage in California. Can you share the value added by workforce diversity and the impact that culturally competent healthcare has on patients and outcomes?
Yeah, absolutely. So one of the areas of expertise that I bring to the table is that of physician workforce diversity. And I think regardless of where we're sitting, I think we can all agree, have a shared goal of the importance of a highly skilled healthcare workforce, quality care for our patients, regardless of who we are. And Latino communities deserve that high quality care, deserve that type of care, that type of healthcare team that they can confide in, that they can trust, that they can bring their concerns to in their own language. I was mentioning, so I was 5 years old when I decided I wanted to be a doctor. As I was sitting there in my clinic visit with my doctor, translating for my mom, giving my doctor, who was lovely, giving my doctor my medical history at 5 years old. And when we think about the impact that culturally concordant care has, studies show that when we don't have a provider that speaks our language, when we don't have a provider that shares our cultural or our social background, or when we experience racial bias, we can't trust in our provider. And shared decision-making, the ability to have shared decision-making in that clinical encounter is impacted. Shared decision-making is a collaborative conversation with your patient that together you can develop a plan of care that is not only clinically effective, but listens to the values of your patient, a plan that they agree with, that makes sense to them, that they can do. And shared decision making, when there is that concordance, that same background between your patient and your physician, also has financial impacts, so messages you can bring to the Capitol. Lower healthcare costs, lower expenditures because of that relationship that the patient, that trusting relationship that patient is able to have with their provider. I was a Latina physician. I was the first person to look, gee, I wonder how many Latina physicians there are in the United States. So, it's laughable. Yeah, right? So, in our study, we looked at the whole United States. At that time, 18% of the US population was Latino. Latino physicians, Latinos make up only 6% of the United States population, of the United States physician population. Only 6%. Compared to 66% who are non-Hispanic white, who are physicians. They're overrepresented for the population, the general population. And Latinas like myself, we only make up 2.4% of the physicians in the United States are Latina. Yet we are 36 times more likely to speak Spanish than our non-Hispanic white colleagues. And specifically in California, California, at the time of the study, 40% of Californians were Latinos. You think it's better? Still, 6% of Californian physicians are Latino. And again, Latina physicians like myself, only 2.7% of all physicians in California are Latina. And so not only does it matter for trust and shared decision making, we know that Latino physicians, having that shared background, patients will have fewer ER visits, fewer hospitalizations, and improved healthcare costs. So we know that they're receiving good care. We know that our patients are healthier. There's something we're doing right. And so we need to think about not only how we do it on the individual level, right? The mentorship that we're doing of our students and our residents. What are the programs that are supporting our students? Because guess what? Although in the US population, only about 33% of Latinas are immigrants, 40% of physician Latinas are immigrants. So a lot of us are immigrants. So what are we doing? Why aren't our US-born Latinas also becoming doctors? What are we doing wrong as a system? And so enabling them to also become physicians and setting up the policies that are going to ensure that highly skilled workforce that we can all agree on, that we know is important for quality care.
Thank you so much, Dr. Anaya. You reminded me of when I was a young child having to also translate for my mom and my dad in those rooms that a 5-year-old shouldn't be in, but you are because you want to help your family. And it's the only way sometimes our children are put in really difficult places. And with that, Assemblymember Bonta, so as the new chair of the Assembly Health Committee and as the first Afro-Latina to serve in this capacity, you have a powerful role in vetting state policy focused on tackling the health disparities, and you already shared a little bit about your own lived experience. Can you discuss any efforts to address these racial disparities in maternal mortality rates and ensure equitable healthcare outcomes for all Californians? AB 3161 has already been mentioned, but what role does implicit bias in healthcare delivery, what does that look like?
Yeah, and I want to thank Dr. Robles and Dr. Anaya for lifting up some of those aspects. It's the weathering that you talked about, the social determinants of health, the ensuring that there's culturally concordant care. So I stepped into the role of Assembly Health Chair as me, right? A Black Latina, the first to be able to hold this position, and brought everything that I knew to the table. So one thing that we did was we started to center our experience. We had a hearing that talked about diversity and equity and inclusion within our workforce, and really highlighted a lot of the data points that Dr. Anaya brought to the table and the impact that that has on ensuring that Latinos and people of color actually have care that they can trust and believe in. And it's not only our physicians, it's the lack of investment in different programs like our Promotora program that ensures that people with lived experience who are part of our community actually have the resources and availability to be able to be those bridge builders for our community members. So we've shown a light on that. Part of that, I also get to sit on the health committee, subcommittee for budget. California is experiencing a $78 billion budget. When you go walk through the buildings right now, you should really be focusing in not only on the legislative priorities, but highlighting for every single assembly member that they need to make choices in the budget around us. They need to make sure to preserve programs like the Promotora program, like the loan program that we give to physicians so that they can then reinvest in our communities and have an ability to actually pay for medical school and not experience. How much debt did you all have? Hundreds of millions, thousands of
Can't talk
dollars.
about it. We're not gonna talk.
Can't Shh. Traumatic to even name the
PTSD.
number. Yeah.
Where's Marlene Garcia?
So making sure that we're creating strong pipelines for healthcare workers, absolutely critical. A lot of that is done through the budget. Making sure that we're preserving programming for our promotoras, a very effective, known to be successful program. Ensuring that we're projecting the dollars for loan forgiveness programs so that we have more physicians who look like us and are like us in that capacity is critical. Ensuring that we're actually creating and saving a robust Medi-Cal reimbursement system right now. Our doulas and our maternal health care workers are paid, pennies on the dollar compared to others in the Medi-Cal system. That's not okay. So those are the kinds of conversations that you should be having with the legislators that you're about to talk to. And then there are pieces of legislation that I'm focused on and many of my colleagues are focused on to really be able to lift up and hold accountable our healthcare system right now. Whether it's my bill that ensures at an institutional level that we're looking at the data from a demographic standpoint. That's code for we're looking to see the impact on Latinos. In California, we're not allowed to talk about race, apparently. Boo.
Yeah. That's right.
And ethnicity. But it is the thing that we know that unfortunately is the driver for us to experience the disparities that we do, particularly in our healthcare system. So whether it's my legislation that looks at ensuring institutions have the ability to be held accountable by looking at those adverse health outcomes and instances and having to track them by demographic data, by ensuring that they're putting together a safety plan so that it doesn't happen again to the next person, the next Latino that comes through their doors. Those are things that we all need to do. I'm so thankful that you are about to step into the role of advocate or continued advocate, and that you're gonna walk the halls and talk about the budget crisis that we're in, but talk about it from the perspective of the opportunity costs on our people. When we don't invest the dollars that we need to, our people die. You all have stories that you can reach into as strong, powerful Latinas that are going to drive the conversation in this legislature. So whenever you hear an aide or an assembly member or a senator say, but the budget, you should say, but what about our people?
That's right. That was beautiful, Assemblywoman. Remember that, okay? You're the expert. When you walk into that room and you go into that building, that's your building. Remember that. So, Tiffany, the Department of Justice has led statewide initiatives to tackle maternal mortality in California, including through a recent investigation highlighting a lack of compliance with the landmark California Dignity in Pregnancy and Childbirth Act of 2019. Can you speak more about what the DOJ's investigation's findings are and how AB 2319 builds on that work?
Yes, happy to. So I'll start out with, what we've been talking about today, and it's a disproportionate rate of maternal mortality among women of color. The United States has the highest maternal mortality rate in the developed world. And in California, the numbers are getting better, but women of color continue to die at 3 to 4 times the rate of white women. So this disparity exists across all income levels, and I will reiterate the fact that a lot of these deaths are preventable too. So to address this, back in 2019, the legislature passed the California Dignity in Pregnancy and Childbirth Act. And this bill mandated healthcare facilities to administer anti-bias trainings. And in 2021, August of 2021, the California Department of Justice led an investigation to ascertain compliance with this act to make sure that healthcare facilities are actually administering these anti-bias trainings. And this investigation was led by DOJ's Healthcare Rights and Access section, and they are charged with increasing and protecting access to quality and affordable healthcare in California. So during the beginning of the investigation, the Healthcare Rights and Access section gathered information from healthcare facilities to see how far along they are at ascertaining compliance with the act. And they found that only 17% of the responding facilities had begun complying with the act, and no employee had been fully trained. By the end of the investigation, 10 months later, 81% of facilities had reached compliance. So this is good, but we want to get to 100%. And so that's what's leading me to the bill I'm going to talk about, which is AB 2319. And so AB 2319 is being led by Assemblymember Wilson, Dr. Weber, and Assemblymember Mia Bonta here today. And this bill is crafted from the findings that DOJ came up with from this investigation. So what the bill would do is it would add specificity to the law so that healthcare facilities will know which specific facilities need to administer the training. It will clarify which providers need to be trained, because during the investigation, healthcare facilities, some of them weren't sure that they needed to do the training or which of their employees needed to be trained. And the bill will also establish firm deadlines for which these trainings need to be completed. So if this bill is passed, the first deadline will be next year, June 1st, 2025, and then every 2 years after that. So this will help guide compliance in that way. And this bill will also require compliance data to be posted online so that the public can see which facilities have administered the trainings and which have not. This might inform someone's decision on where to seek care. And the bill will also add an enforcement mechanism. So there will be some type of accountability and consequence for healthcare facilities if they do not comply with the law. And Addressing inequities in our healthcare system is going to require a multifaceted approach, and AB 2319 is one of the ways to get to a more just and fair healthcare system for all Californians. And I really appreciate you having me here today, and happy to answer any questions.
Thank you so much, Tiffany. And I want to highlight something that I'm hearing throughout this conversation is there is legislation and then there is implementation. And how do you go back and ensure that what you're advocating for is actually being implemented? So thank you so much for that piece. I learned that from my former boss in the building, and we could have all the beautiful pieces of legislation we're advocating for, but if implementation is not happening, there's a gap there as well. Okay, so I think there are cards. Are we doing cards right now? I don't have any yet. Oh, here we go. Wow, that's some good customer service. We're gonna do a couple of these cards, and then we're gonna do a little bit of a more open round out question. Okay, so how can we leverage institutional partnerships to reform maternal health care? What are some concrete steps we can take? And anyone can jump in and answer that.
That's a really great question, and I'm excited to hear the rest of the panel's answers. As a practicing physician, I think it's really important for us in healthcare spaces to really prioritize partnership at the community level, and that we listen to the community. This is not a novel idea, but I will say in my medical training, it wasn't something that was really emphasized until I was out of residency and in fellowship, and now as a fully licensed physician. I think the importance that we need to make sure to know as healthcare providers and healthcare systems is that, the community has the answers. The answers exist. There are so many stories of success, of resilience, of, we as many times, and I painted, a bit of a grim picture with regards to some of the disparities and adverse outcomes that are localized in the communities of color. But for every hardship, there are countless stories of success. And I think that's an important reminder that folks in my position need to sit down and listen and open our ears, open the door for those partnerships and those conversations. So the concrete step that I'd like to remind myself and to charge those in leadership in healthcare spaces is that door needs to be open. We need to be ready to listen, and then to take those conversations in partnership, side by side with the community, not this implementing the same kind of medical hierarchy that very much exists in my training and in my practice, but very much side by side, or even better, with us taking the step back, with us delivering the resources, the space, the audience, and to really let our community leaders make those changes.
Thank you. Anyone else?
Jump in and love on my district a little bit. So I think one of the most critical things is that the point of care, that we recognize that the point of care is really community-based. In Oakland, we have the Unity Council and La Clínica de la Raza, and we have Asian Health Services. Like, those community-based health clinics are the ones who actually see the majority of our community members, because they are a trusted source of care that have been there for decades. And one of the things that I really appreciate about Oakland is that our hospital, our major hospitals have kind of gotten clear on that. Kaiser, Sutter, Summit, they all are really working on having legitimate partnerships with those healthcare clinics. It took changes in leadership at the top level for that relationship to happen. And what that means is that they are investing in, they are partnering, they are providing mutual support and training, but they're recognizing that the primary, where we want to go, are the people that we trust who speak our language, who look like us, who understand how to counsel us to eat the food that is the food that we like, but that is healthy, all those kinds of things. So I think it's absolutely critical, and it's behooves all of the major health care insurance companies and major health institutions to recognize the power of community as the frontline workers.
Thank you.
If I can add, Assemblymember Bonta was pointing out the importance of community health workers. When you've got that lack of trust, because we don't have the workforce, and our research shows it would take 5 centuries to build up that Latino workforce, to build up that shortage, we have community health workers who can be the bridges, who can be that trust. And so important that we have that continued partnership with folks that are coming from the community themselves, who can represent the needs of the community, and can also, as we were sharing earlier, we are resilient. We are resilient and we are healthy, and even though the narrative is of us not being healthy, oh, Latinos are diabetic, oh, Latinos, we're healthy. We actually have lower mortality rates than others. And so how can we change the narrative using the community voice, partnering with our community voice?
I love that so much. Another shout out to my colleagues. We have a wonderful Promotora Comunitarias program, and if it's not for them on the ground doing the peer-to-peer work, we would see more difficult and challenging issues. I think we are out of time. We do have one more question, but we actually answered the question earlier around the fiscal impact and the state budget deficit. So the question was focused on the state budget deficit, but as Assemblywoman Bonta said, we push back on what they're going to tell you in the building. When they say it's too expensive, you're going to say, my life is worth it. Our children's lives are worth it. Punto, period. Thank you so much for your work.